Good afternoon and welcome to today's webinar, The Hidden Value of Laboratory Medicine, How to Leverage Laboratory Stewardship to Your Advantage. I'm Shannon Whitney and I'll be your moderator for today's event. We are delighted to bring you the LabLeaders webinar series presented by AACC and supported by a generous grant from LabLeaders. This program is accredited for Accent Continuing Education credit. I'd like to point out that our webinar will conclude with a Q&A session. You can submit your questions at any time during the webinar through the Q&A dialog box in the bottom right-hand corner of your screen. However, those questions will not be answered until the Q&A portion of our program. Please note that there is a Q&A dialog box as well as a chat dialog box. To ensure that your questions are received and included, please only submit through the Q&A box. To check that that box is open, please confirm that the Q&A box is visible in the right-hand side of the screen. If it is not, click the Q&A icon from the options in the bottom center of the screen, which will turn the icon blue. Your Q&A dialog box will then become visible. So let's get started. As a global leader in healthcare, Roche Diagnostics has made the promise to empower laboratories and the people within them by providing clinical and strategic insights, support, and solution from the industry's top innovators through LabLeaders.com. So again, thank you for joining us for today's LabLeaders webinar, The Hidden Value of Laboratory Medicine, How to Leverage Laboratory Stewardship to Your Advantage. Today's speaker is Dr. Jeffrey P. Pearson. Dr. Pearson attended medical school and pathology residency at the University of Michigan. He did a surgical pathology fellowship under the direction of Sharon Weiss and was focused on being a surgical pathologist when he signed on to work at the Bronson Hospital in Kalamazoo. Through no fault of his own, he unexpectedly became the medical director of the clinical laboratories for the Bronson Health System, and for the last 15 years has been trying to figure out how to be a better medical director. His current focus is on promoting the value of the hospital laboratory and creating a successful business model for clinical pathology. Dr. Pearson, you may now begin your presentation.
Okay, thank you for having me and Happy New Year to everybody. I want to start by, again, stating that I am an AP-CP pathologist. I'm in private practice, and I read surgical pathology slides every day, but I also direct multiple laboratories in our hospital system. And I have this belief that much of what we do as clinical pathologists and as laboratorians is really hidden and underappreciated and undervalued. So today what I want to do is share a series of stories with you about what has worked and what has even sometimes failed as we've tried to build a value-based laboratory in the Bronson Health System. So I will begin now. Again, my title is The Hidden Value of Laboratory Medicine. And I want to start off by talking about, our laboratory used to be considered a profit center. And in the old lab, the way things would work was that you would send specimens into the lab, you'd wait overnight for results, you'd get a report that you'd send back to the clinicians, and we were really judged on our bottom line. We were judged on our cost per test, we were judged on how much money we were making. But times have changed. We're switching more to a value-based system in the laboratory. That involves a lot more things like pathologists having direct face-to-face interactions with the medical staff out there. It has a lot to do with bringing on new lab tests that improve patient care in real time. And it always has to revolve around, improving quality, lowering cost, and increasing the service that we provide to our patients and our clinicians. So it becomes much more important that we figure out how to build a value-based laboratory and then also how to get credit for building that laboratory. So my objectives today, number one, I want to outline some of the tenets of effective laboratory stewardship, some of the things that have worked here at Bronson. I want to talk about how some of the new lab tests and new technology that we've brought on really improves patient care in real time. Number three, I want to demonstrate that the value of laboratory testing is really optimized when pathologists are out there interacting with the clinical care teams. And then number four, give some examples of how to leverage your success in utilization management to your advantage with your hospital leadership, how to get some credit for that. So my first topic has to do with laboratory stewardship, and this is sort of my definition. It's guiding how clinicians order laboratory tests to improve the quality of care while reducing the cost to the patients, the hospitals, and the overall healthcare system. So my topics I'm going to start with is, one is how to improve reference lab testing. Most of our hospitals, we are used to having million-dollar budgets or multi-million-dollar budgets for send-out testing. It's very important center of cost for what we do here. So I'm going to touch again a little bit on boutique third-party laboratory testing, some on obsolete testing, and what to do when you get unreasonable test requests. Okay, so what we did is we did a study. We looked at our top 20 boutique lab send-out tests. So we have a reference lab that we prefer to use. We encourage our doctors to use that. And we were like, wow, you know, this reference lab that we use is really fantastic. It's a world-class laboratory. They test for almost everything. And if they won't do these tests and they're sending them out somewhere else, what's going on? You know, why are we allowing our clinicians to send these out? So we did a top 20, and you know, don't try to decipher the slide and look at every test there, but I want you to know is we looked at each of these 20 and we tried to make an evaluation. Could we do it in-house? Could we do it at our primary reference lab? Or maybe it was an obsolete test that didn't need to be done at all. And I could give you a number of different examples, so I'm just going to give you one example of what we found, and that was teichoic acid antibody. So I've been a pathologist for 20 years. I had never heard of this test before. So I did what most of you would do, was I got on Google and I searched it. And all the literature that came up on teichoic acid antibody was from the 1970s. I'm like, whoa, that's not a good sign if it's all that old. And so what I did is I contacted a friend of mine at the reference lab that we use, and he says, hey, you know what? We've not done this test at our institution for like over 20 years. Nobody orders this test anymore. The idea was it was supposed to be a surrogate marker for staph infections, but the truth is it never worked. It was like a flip of the coin. But he says, you know what? I know the director at Focus Labs. Let me give him a call and ask him why we still do this, why he's still doing this test. And you know, at our institution, we were doing 150 of these a year with $100 a test. It was like $15,000 a year just going down the drain. So my friend from the reference lab gets back to me and says, yeah, you know, I got a hold of the director at Focus Labs, and he says, yeah, I know this isn't really a very good test, but it's supply and demand. And you know what? There's this hospital in Michigan, I think they're called Bronson, and they order more of this test than any other hospital in the entire country. So I was really embarrassed that we were the #1 order of this test, and that it was, you know, it was one of the reasons that Focus Labs was still doing it was that we were ordering so many of these. So it was one of those rare decisions where I made an executive sort of order that we would not allow this test to be ordered anymore. And you know what? The next day after I did that, I got one angry phone call, and it was from one of the older ID docs who probably trained back in the 70s. And he was literally teaching the hospitalists to order this test. And that's why we had so many of these. I told him we weren't going to allow it anymore. I had kind of one angry phone call, and then I never heard about it ever again. So sometimes you have to sort of put your foot down and say, no, we're not going to allow an obsolete test to be sent out. So we looked at those top 20 tests, and as I mentioned, some of them we found we could do at our primary reference lab. Some we found we should not allow at all. There's a couple we were able to move into our own laboratory, and by making that one exercise of, you know, spending a number of hours going through that top 20 list, we cut $100,000 out of our send-out budget. So again, the moral of the story here is you got to pay attention to what your clinicians are ordering. If you're not checking out what they're doing, they could be ordering any, you know, old crazy test that really doesn't make sense to let them go out. So part of my message is it's good to have a formulary. What we've done is we have a certain set of tests that are on our formulary that we allow to go to third-party labs. We have others that we don't. And really don't let your clinicians pick and choose their own reference labs. You really need to stick with your own unified reference lab. So the other topic here is obsolete lab tests. And I just threw up a few examples, you know, bleeding time, bands, which are just imaginary cells that no one can really count anyways, H. pylori serology, red blood cell folate, CKMB, and I thought I'd just give you an example of what happened when I tried to get rid of CKMB, because this turned out to be kind of an interesting story. So I was reading some articles and found these really great articles in the literature. I really like these titles. You know, The Requiem for a Heavyweight, The Demise of CKMB. This was written at the Mayo Clinic by Amy Sanger and Alan Jaffe, and they had gotten rid of CKMB more than 10 years ago. And then another really great title I saw was Creatinine Kinase MB, The Journey to Obsolescence. So I just really like these titles, and I was like, wow, what are we doing still doing all these CKMB tests in our hospital when these articles are stating that it's useless, that we shouldn't be doing them anymore. And so it turned out we were doing 14,000 of these per year at Bronson, and I was like, I'm not really sure how much these cost, but I just took a stab. So what if they cost $20, you know, between the time it takes a phlebotomist to draw them, the reagents in the lab, et cetera. And if they cost $20 a piece, then we're spending over $300,000 a year on an obsolete test. So I decided to take this to the emergency department doctors and gave a presentation to them, talked about how this is becoming an obsolete test, that troponins more sensitive and specific. And to my surprise, the ED doctor said, yes, we agree with you, Dr. Pearson. We're going to take this off of the menu. We're going to teach our residents not to order it anymore. And by making that intervention with the ED, all of a sudden, we cut out about 50% of these tests. And they dropped down to about 7,000 per year. But then that still sort of begged the question, well, who's ordering the other 7,000? And it turns out it was mostly hospitalists and cardiologists. So I contacted the hospitalist, and their response was very adamant, don't blame us. The cardiologists are telling us to order this. So, you know, you're talking to the wrong people. So I thought, well, you know what? I had good success with the emergency department doctors. So I'm going to go ahead and meet with the cardiology team. And so they have a performance improvement committee, and I met with them, and we're all sitting at a table. And what I'm going to do is share with you some of the slides, just a few slides that I presented to them, because I thought I had some pretty good evidence. And you can kind of picture things like I had cardiologists, cardiothoracic surgeons. They're all lined up on one side of the table, and then there was me and some of the support staff on the other side of the table. And I thought, okay, you know, I had good success with the ED. This should go okay. And I started out with, okay, here's the cardiac biomarker kinetics. And I said, look, you know, troponin appears in the bloodstream sooner, it peaks higher, it lasts longer, you know, it shows up faster, it's more sensitive, it's more specific. CKMB is present in your skeletal muscle, et cetera. You know, this is really a much better test. But I said, well, if that's not good enough for you, let me give you some evidence-based medicine. And I actually quoted both the Mayo article and the University of Missouri article, but I gave them the status. So in Kansas City, they were doing the same thing. They were doing 12,000 of these a year, and they decided to remove it from all their panels, but they let their doctors still order it on an a la carte basis. So all of a sudden, their volume dropped to about 150 a year. And then what they did is they did a chart review of each of those 150 cases, and they found that CKMB contributed nothing to patient care, 0 out of 150, and that it just wasn't valuable. And they actually took it off the menu. I mean, their conclusion was it doesn't add any value. It can be removed from the laboratory menu, and they made it completely 100% unavailable. So while I'm giving this presentation, the cardiologist who's kind of in a leadership position, he's sitting right across from me, and I see him, he starts to move. He's like twitching. He looks very disturbed and very unhappy, and I'm like, and he's a really big guy. This guy's built like a college football tight end. He's like 6'4", 240 pounds, and you know, he's very intimidating figure. So I thought, okay, well, here's my coup de grace. I'm gonna quote the American College of Cardiology, and they say, you know what, CKMB and myoglobin are not useful for the diagnosis of acute coronary syndrome with a level of evidence of A. And I even make this comment to them, you know, it's not a A- or a B+, it's an A. I'm like, you know, come on, guys. And I thought, okay, great, you know, I presented this. And when I finally finished, the cardiologist that was sitting across from me just lost it. He pushed everything away from him. He pointed his finger right at me and he says, I'm not letting any pathologist tell me how to practice medicine. He says, I am a real doctor. I save lives, and you're not going to tell me how to practice medicine. And then so at our performance improvements committees, we usually have an executive on the team. So there was an executive at the end of the table, and she used to be an obstetrician, and she actually stood up and said, you know, Dr. So-and-so, this is evidence-based medicine. You really need to listen to this. And he just points his finger at her, and he says, I'm not letting any ex-obstetrician tell me how to practice medicine. You know, I make life and death decisions every day. And I'm like, oh my gosh, you know, who is this guy? I mean, obstetricians also make life and death decisions. I really can't believe he's behaving like this. And then, so then finally he takes a little memo that he'd created about why they still wanted to do CKMB, and he kind of throws it at me and passes it out. And I kind of slunk away from this meeting feeling totally defeated that I'd done the wrong thing, that I'd really miscalculated. And I took his little memo back to my office, and I finally got around to reading it. And the article that he referenced was written by Alan Jaffe. And I'm like, wait a minute, this makes no sense. And I looked up the article that he referenced and had a really great quote in there. And it said, you know, CKMB should not be used anymore. You know, troponin is the gold standard. And the only reason I can see for using CKMB is if you live in a third world country and you don't have access to troponin. And I was like, oh my gosh, I don't think Kalamazoo is a third world country. I really don't think we should still be using this. So my response to this was I sort of had to isolate this one individual. I kind of worked with everyone else, the hospitalist, the ED, the other cardiologists, and eventually get everyone else to stop using this. And you know what? Now he doesn't order it anymore either, and we're able to finally get rid of this. But my point of telling you this story is sometimes you run into a buzzsaw. Sometimes you run into resistance despite your best efforts, and people give you the wrong reaction that you're not expecting. So my next topic is, well, you know, every time something difficult comes up, you don't always know the answer. And sometimes I have to look for help. And one of the things that I use is we belong to PLUGS, which is the Patient-Centered Laboratory Utilization Guidance Service based out of Seattle Children's Hospital. And they're really great. If you belong to them, you can get on the phone, you can send them an email, you can ask them questions about what you're stuck with. And again, I'm going to give you just one example. And again, PLUGS is really known for genetic testing, but I had a problem. I had this order for zinc red blood cells. And I'm like, what is that? What is zinc red blood cells? Who orders this? And the doctor who had ordered it, he practiced what was called holistic medicine. And, you know, I'm okay with that. I know people like to dabble in different things, but I kind of like still was, what is this zinc red blood cells? And I actually got a call back from Dr. Astion from PLUGS, and he said, you know, Jeff, he said, first of all, he says, this is quackery. That was the first word he used. This is quackery. This is not, you know, evidence-based medicine. And he says, you know, here's sort of the idea. The idea is that people think this is kind of like hemoglobin A1C, you know, where you're measuring red blood cells over 90 days, and it's a better snapshot of the nutritional status. But there's a couple problems with this. One, your zinc levels don't fluctuate throughout the day the way your glucose levels do. And number two is there's no scientific evidence that shows there's any benefit to measuring your, quote, zinc levels in red blood cells versus just getting a serum level. So he says, Jeff, you know, you should talk to this doctor that's ordering, but you don't want to tell him this is quackery. So here's what you should tell him. You should say, you know what, if you want to practice black magic, you go ahead and practice black magic, but I'm not going to practice black magic because there's no evidence to do this. And I was like, wow, thanks, Mike, but, you know, I'm not sure that's really what I want to say to him. So I get this guy on the phone, and I used all the usual quotes, evidence-based medicine. You know, I quoted one study that I could find that showed there was no evidence to this. And, you know, the doctor on the other end, I could kind of tell he's just nodding his head. He doesn't really say anything. And so I do my best. And 2 weeks later, you know what happens? One of his patients shows up at our hospital lab with an order for zinc red blood cells. And he wrote in big letters, this is handwritten on the requisition, do not go to Bronson. That was his response. Of course, his patient showed up anyways, showed how crazy that was. And again, it's another example that sometimes despite your best efforts, people won't listen to reason, and there's not a whole lot you can do about these things. However, we still don't participate in this, and we won't send out some of these zinc red blood cells, manganese red blood cells, copper red blood cells, et cetera. We've just kind of drawn the line and said, we won't do that. So my next topic is Technologic Advancements. I'm going to give you a couple examples of things that we've brought on in our laboratory that have been successful for us. One is molecular diagnostics and microbiology. And again, these are expensive tests. You rarely get reimbursed what these tests cost you, but the payoffs come down the line. And I'm going to talk about how to show that. The other topic I want to cover is high sensitivity troponin. It's not a more expensive test. It costs the same as the old test, but it has really great potential. And we have experience with both of these, so I'm going to touch on that. So starting with microbiology, blood cultures and sepsis. Sepsis is a very hot topic right now. Every hospital is working on their sepsis guidelines. So we looked at our blood culture turnaround times, and we looked at 2 different hospitals, Bronson Methodist, Bronson Battle Creek. We looked at our turnaround times for our cultures, and it was taken 3 days. So that was from the time we drew the blood to the time we actually got to the ID. And 3 days is a long time. You know, it's really a delay in treating sepsis. And we kind of thought, well, what can we do to make this better? And also we were interested in consolidating to just one laboratory. We wanted to kind of demonstrate we could do this more efficiently. So we brought on the PCR multiplex technology. And the difference in this is instead of taking, when you get a positive blood culture, when you do it biochemically, you've got to plate it out, you've got to wait for the cultures to grow again, then you got to run them through the Vitek to get your result. Well, with PCR technology, you can get a result in 1 to 2 hours, and you can do that 24/7, round the clock, and all these different organisms can be identified. So what we set up was that we would notify pharmacy, whether it was 2 in the morning, 3 in the morning, any time that it occurred, we'd notify pharmacy of the results, what organisms we had identified, and then they could make an intervention in the patient care. And we were able to show a 40% drop at BMH and a 45% drop at BBC in our turnaround time for IDing these organisms. And so when you show that to your administration and to your executives, those are very impressive numbers to say, look, this is how much time we're able to cut off. Yeah, we brought in new technology. Yeah, it's expensive, but there's a big payoff in bringing this in. And the payoff is in better patient care and hopefully better outcomes in our patients that we treat for sepsis. So we thought, wow, what other departments can benefit from rapid molecular diagnosis? So the next thing we did after doing this PCR technology was we looked at our emergency departments, and we've since brought in gonorrhea, chlamydia, trichomonas. We run that by PCR. Now we do this in the core lab, but we support 4 different hospitals, 4 different emergency departments, and we get a turnaround time of 1 to 2 hours on these. So we also do the flu testing at all 4 hospitals. We do strep A. Of course, the advantage of doing strep A by PCR is you don't need any culture backup. And we have gotten really great feedback from our emergency department doctors. They say they're given better patient care, that they can treat these patients while they're still in the emergency department, because a lot of emergency department patients, they're not the sort of people you can follow up with. You lose them to follow up. They don't necessarily show up for appointments afterwards. So our emergency department doctors were really happy with this. They said it impacts the patient at the point of care. It makes a real difference in their outcomes and how they are doing. So we thought, wow, we're doing really great. We've done this blood culture thing. We've done this rapid diagnostics in the ED. So another thing we looked at was the respiratory infectious disease panel. Now this is different. This is a very expensive test, and I don't recommend that you do this on outpatients. Not really good in the emergency department unless you're thinking about admitting someone. But we thought, wow, this could be a really effective test, because think how many patients are admitted with respiratory disease of unknown etiology every day in our hospital. So what we found when we brought this on was we could identify all these different types of viruses, bacteria, again, very rapidly. And when we were looking at flu season last year, we were having over 400 cases of flu in 1 week in our hospital system. And this chart just shows that in the 4th week of last year, 2018, which would have been in January, that was our peak of the entire flu system. And this shows all the different viruses that we were identifying in these patients at that time. And again, we don't recommend the RIDP for outpatients, but we thought, wow, what impact is this having on our inpatients? And so we contacted our EPIC team, we put in a request, and they actually ran a financial analysis for us. And here's what they came up. They did the before and after analysis, before we had the RIDP and after. And so they looked up various diagnostic codes. So one was acute respiratory failure with hypoxia. So before, the charges added up to $60,000. Afterwards, they were only about $38,000. Wow, that's a 36% drop. So we thought, well, we better look at some other codes. So we looked at community-acquired pneumonia, same thing. Costs dropped by about 45%. Looked at just the plain old diagnosis of pneumonia. Costs dropped by about 38%. And I was looking at these numbers and I thought, these are too good to be true. This just can't be right. It can't be accurate. So I went to a meeting with the Hospitalist team, and I showed them these numbers and expressed my doubts. And they came back to me and said, oh, no, Dr. Pearson, you're wrong. These numbers, we really believe these numbers are true. This is an incredible tool that we have for treating patients. It really allows us to cut down on the amount of antibiotics we're given. It helps us get patients out of the unit when we can figure out that they have a viral infection as opposed to a bacterial infection. And they said, we really believe these results. This is one of the most important tests that you've given to us. So I was like, wow, that's really reaffirming to know that we can bring in a test that we're probably losing, we're spending, over $100 per test in the lab, but the payoff down the line is in the tens of thousands. So this is really important to demonstrate this value that you get down the line outside of the laboratory. So my next topic, my second example of new technology has to do with troponin and the new high sensitivity troponin. So again, this is something that really occupies your emergency department. There are 8 to 10 million presentations in the United States every year for chest pain. And yet, there's also a 30 to 40% admission rate. And when I say admission rate, an awful lot of these patients are admitted for overnight observation. And then they get stress tested in the morning, and they're watched to make sure they're not having a heart attack, because nobody wants to send someone home who's having a heart attack and be faced with that. But there's only 735,000 heart attacks diagnosed in the U.S. every year. When you compare that to roughly 10 million visits, you can see that less than 1 in 10 of these presentations is actually having a heart attack. So 90% of the time or greater, they're actually having other causes, whether it's GI causes or pleurisy or musculoskeletal. They're having other causes of their chest pain. So your real challenge in addressing these patients is the rule-out process. Ruling in isn't actually the harder part. It's the rule-out process. It's getting patients released that aren't actually having a heart attack. So the fourth universal definition of myocardial infarct just came out towards the end of 2018. And it's very interesting because this is the first time, the last definition was in 2012, I believe, where they actually incorporate high sensitivity troponin into their definitions, into their protocols. And they make a very important distinction that myocardial injury is any value of troponin above the 99th percentile. That means there's injury to the myocardium, but it doesn't mean they're having a heart attack necessarily. If they're having a myocardial infarct, you really need to see a change in the troponin. Again, most of the time it's going to be going up. Theoretically, if they came in and presented quite late after their chest pain, it could actually be dropping. But you need to see a change. So you really need to see multiple levels of troponin. You need to see a delta. You need to see a change. And now this is built into the new definition of myocardial infarct. So I mentioned again, myocardial injury is just having your troponin elevation above the 99th percentile. But look at this chart. There's more than a dozen different causes of troponin elevation. Of course, what we're worried about are type 1 and type 2 myocardial infarcts. But you know what? Chronic kidney disease will give you an elevated troponin. Congestive heart failure will give you an elevated troponin. And arrhythmia theoretically can give you an elevated troponin. There's lots of other causes. So what you got to do every time you have one of these patients is you got to picture this chart in your head. And you got to say, am I dealing with a chronic myocardial injury, in which case it'll be like this blue dashed line. Your troponin will be steady. If you get a value at 2 hours and then again at 4 hours, it's not going to change. It's going to stay steady. So again, a great example of that would be chronic kidney disease. However, if they're really truly having a heart attack, you're going to see that troponin go up. It's going to elevate. You're going to see a significant delta. So you really can't make a diagnosis generally based on one troponin value. Certainly, if you have the EKG results to go around with it, if you have an ST segment change, et cetera, you can make the diagnosis. But most of the time, you need to look for the delta and figure out, are they on this purple ascending line or are they on this blue dashed line? So the advantage to high sensitivity troponin, again, it's not really that you can necessarily diagnose a positive faster. The real advantage to this is your negative predictive value. So the more sensitive that your troponin is, the greater the likelihood that you can get a patient out of the emergency department early, send them home, avoid having to admit them for diagnosis, avoid having to do a stress test, et cetera. So I like to quote this article. It was published just in 2017 in Clinical Chemistry. And there's different protocols that you can use for high sensitivity troponin. You can use a 0 and a 1 hour protocol, you can use 0 and 2, or you can use 0 and 3. I've looked at different institutions. I've looked at Mayo Clinic, they're doing 0 and 2. I've looked at Geisinger, they're doing 0 and 3. Cleveland Clinic has a 0 and 1 protocol. There's different ways out there that you can do it. But again, the real advantage of this is the negative predictive value. This particular study looked at a 0 and a 3 hour protocol. And they found if they had 2 negative troponins and, a normal EKG, they could rule out an MI, and their negative predictive value was 100%. And that was even if they followed the patients out for 30 days. So again, that demonstrates the power of a high sensitivity troponin, is that you can confidently rule out myocardial infarct, oftentimes after getting 2 negative values with your troponin, and then send them home and avoid all these problems with having to have admissions, observation, a lot of stress testing, et cetera. So this is a really great study. This European literature, they've been using troponin high sensitivity for 10 years now. So there's a lot of really great European literature. This is sort of, again, a before and after study where they showed a 20% reduction in the amount of time spent in the emergency department, and they showed a 20% reduction in cost. And in addition to that, they showed a 30% reduction in the number of stress tests that they were doing. At the same time, the actual number of heart attacks didn't really change, and that means that the number of coronary angiographies that they were doing didn't really change. So the interventions that they did remained about the same. The number of procedures they did remained about the same, but their rule-outs were significantly improved, able to get more patients out sooner. So this is a lot of information that I presented to our doctors as we were planning on bringing high-sensitivity troponin on live. And when we finally did bring it live, we've only been live for 1 month now at Bronson. We brought it on, well, really 2 months, but I've only have 1 month of data. We brought it live beginning of November and realized how hard it is to educate an entire hospital system on the difference between the old standard troponin and then the new high sensitivity troponin and the different rule-out protocols we had to go through. But even after 1 month, we've already seen a significant change. We've seen our length of stay in the ED already drop from 9.5 hours on average down to 7 hours on average. We've seen our stress testing drop from 82 per month down to 39 per month, so that's a drop of like 50%. And we've also seen a lot more discharges directly from the emergency department. So with the old method, we had about a 48% discharge rate directly from the ED, not requiring any further observation, versus with our new high sensitivity troponin, we're closer to a 60% discharge rate where they don't have to have further evaluation. And this is only after 1 month, and I can guarantee you a lot of our doctors are still learning how to use this troponin, and I expect these numbers to actually get a lot better with time. So again, that's another success where you can show actual cost savings to your hospital system. So my next topic is, well, what's the pathologist's role in the value-based laboratory? So again, the topics that I'm going to touch on are how pathologists can get involved in molecular testing, how we can get involved in blood conservation, how we can get a diagnostic management team going, and how we can use clinical decision support tools. So my first example is a pretty good one. Oncologists do bone marrow biopsies all the time. A common example might be for Pancytopenia. Our oncologists have a very broad differential diagnosis, including leukemia and lymphoma. And it used to be they would order all these ancillary tests, JAK2, PCR, BCR-ABL, et cetera. You know what we would do? We'd send them all out, and the cost would add up to thousands of dollars. And nobody really second-guessed what they were ordering. But what we do now instead is we have the pathologist evaluate the bone marrow biopsy before the ancillary testing is going out. We made an agreement with our oncologist. So say that the pathologist recognizes, hey, this is lymphoma, it's not leukemia, it's not myelodysplastic syndrome. I only need a very few tests, I can cancel all these. And now we let our oncologists know we're going to cancel these tests. We're not going to send them out, and our oncologists are good with this. And in fact, for the most part, now they don't even order the ancillary tests anymore. They let the hematopathologist order these tests, and that theoretically saves thousands of dollars per bone marrow biopsy. So my next example is personalized precision cancer care. I'm going to give you a real-life example of someone that I actually know and still know. She was a previously healthy female. She was in her 60s. She had just retired, and she had this back pain that just wouldn't go away. So they got some imaging studies, and you know what? It showed a lytic lesion of the spine. And I actually talked to the family, and these are friends of the family, and I said, there's really nothing good that causes lytic lesions of the spine. And I said, most of the time when I see this, it's multiple myeloma. That's a cancer of plasma cells, and it has about a 4 to 5 year prognosis. We're going to have to try and figure out what this is. So spine actually then developed a fracture. She had to go to emergent surgery, and they did an intraoperative consultation. And you know what? It didn't show plasma cells. Unfortunately, it showed adenocarcinoma. And the adenocarcinoma was CK7 TTF1 positive. That means it was coming from the lungs. She had a lung adenocarcinoma, got a referral to the University of Michigan, and this was really terrible. They went from thinking, oh, gee, you know, I'm dealing with a disease as maybe a 4 or 5 year prognosis to metastatic adenocarcinoma from the lung that had like a 3 or 4 month prognosis. So again, I counseled the family and I tried to explain to them, well, you know, there's molecular studies we need to do on this. And it was really sort of hard to get them to understand that. So they were literally in the car driving to their appointment in Ann Arbor, which is a couple hours away from here. And while they were driving, I actually got the molecular results back, and it showed that she had the EGFR mutation. And what this means is this tumor can respond to tyrosine kinase inhibitors. So I wasn't going to try and contact them in the car. Instead, I just used the old-fashioned fax machine. I dropped this in there. I faxed it directly to the oncologist in Ann Arbor. And then they told me a couple days later what had happened is they were in the waiting room waiting for the oncologist to walk into the examining room. And when she walked in, she had this big, huge smile on her face. She was like exuberant. She was happy. And they couldn't understand why this doctor was walking in and looking so happy to tell them that they had this, you know, lethal disease with a poor prognosis. And instead she walks in and says, I have great news. You have the EGFR mutation. This is a treatable cancer. I can treat you for this. And of course, they were completely floored. They had no idea that this treatment was available. And you know what? This patient had an incredible response. And this isn't actually her scan. It's just an example. But you can treat these types of lung cancers with drugs like Tarceva, tyrosine kinase inhibitors, and they literally melt away. And now 2 years later, she is still doing really well. Her bones in her back have actually healed back together, which is totally amazing. They've kind of grown back and fused back together, and she's doing really well. So it's a great example of precision medicine and the role that pathologists can play in that. So my next example is blood conservation. It used to be I could talk a whole hour on blood conservation, but now I can share with you two numbers, 7 grams hemoglobin and 1 unit at a time. If you can do these two numbers, you can do 80% of blood conservation and accomplish that. So 7 grams has to do with the transfusion threshold, that whether the patient's in an ICU, whether they're having orthopedic surgery, even if they're an alcoholic who has a GI bleed with cirrhosis, you don't need to transfuse them above 7 grams hemoglobin. There's really great published studies, evidence-based medicine, that they actually do a little bit worse when you over-transfuse them, and they do better when you keep their hemoglobin just above 7. The other thing is only transfuse 1 unit at a time. I remember hearing doctors say, well, you better not give 1 unit at a time. If you're going to transfuse them at all, you better give them 2, or they don't even need the blood. You know, that kind of mentality. Well, now we really push transfusing 1 unit at a time, see how they do. Of course, we promote really great intraoperative techniques. We have cell savers, we have TAG, et cetera, and that's important too. But you can accomplish 80% of these with these two numbers. So what we did with our hospitalists is we actually looked at, wow, what was their double unit transfusion rate? And we did an intervention. And we did a scorecard approach for them. So every hospitalist could see their score of what their rate of double unit transfusions are. So if you look at Jose here, he had been giving 12 double units and 2 single unit transfusions. We did the educational, and he bought into this completely. He started giving just single unit transfusions, kind of gave up on the double unit transfusions. Amy was a little bit different. We saw her initially switch to a lot more single unit transfusions. She had a little bit of recidivism, went back to giving some double unit transfusions. But the story is we had about 40 to 50 hospitalists in our system, and after 1 year, every single one of them was in the green based on the scorecard approach. You know, the 3 or 4 that stood out for giving too many double unit transfusions, they all came into line based upon the peer pressure of having the scorecard system. So here was the effect of that. Our double unit transfusions dropped from roughly 50% down to about 16%. So we saw a 2/3 drop in that. At the same time, we saw about a 35% decrease in transfusions given to patients above 7 grams hemoglobin. That translates into real money. So when we had this success at Bronson Methodist Hospital, my pathology team happened to take over the pathology services at Bronson Battle Creek a few years ago. So we instituted the same blood conservation program there. And what this graph shows is that, again, focusing on that single unit transfusion, 7 grams hemoglobin, good intraoperative technique, we were able to decrease their transfusions from over 250 a month down to closer to 100 per month. That was a savings of $375,000 a year. And I tell you, that is a really great way to make friends with the administration when you're involved in a new hospital system, is to show that kind of impact that you can make. So my next topic is the diagnostic management team, which we have a fairly simple diagnostic management team here at Bronson. We meet just once a week. We meet on Friday mornings. We round with the Western Michigan University medicine team, and we discuss our testing strategies. We talk about things like drug testing. We talk about thrombophilia testing. We talk about how to work up tumors, et cetera. We've got a pharmacist on the team, and it works out really well. So we meet with an attending, medical students, residents, and we talk about these. So I'm going to give you just, again, one example of something that we dealt with in our diagnostic management team. And that example is, we had a 54-year-old patient. She had COPD. She was a smoker. She had exasperation of that. They were suspected she had pneumonia, so they started her on antibiotics. And of course, what happened, she got diarrhea the next day, but it wasn't that bad. But the nurse actually called the resident and said, hey, you know, this patient's on antibiotics. She developed diarrhea. You better do some C. diff testing. And sure enough, the C. diff testing was positive. But there's a problem with that. When you do kind of reflex C. diff testing, is that there's a 15% carrier rate. It's actually even higher in the elderly, like in nursing homes. It's very high in children also. And in this particular case, the patient's diarrhea resolved the next day. Yet the problem is she had a positive C. difficile test. Then they want to treat her with vancomycin. That's more antibiotics. And also, as a hospital system, you get dinged. This is a hospital-acquired infection. It gets reported to a database. You get penalized for this. And I actually got some real numbers from our hospital showing the number of hospital-acquired infections. What this graph shows is that the C. difficile infections in 2016 were relatively small, and in 2017 they like quadrupled. And I'm like, come on, there's no way our C. difficile infection rate quadrupled in 1 year. That just couldn't happen. And then also the costs involved. So again, we actually got some data from the hospital. Our hospital-acquired infections were costing over $5 million per year in our hospital system. So again, this is real money that we're talking about here. So we met with the diagnostic management team and said, what's going on? And they said, well, didn't you know there's a hospital-wide initiative to decrease the amount of C. difficile infections? So all the nursing staff have been educated. You know, we talk about things like, you know, disinfection and hand washing and testing. Well, lab wasn't involved in this. We weren't invited to the table, and we didn't get to talk about testing. And an unintended consequence was the nursing staff became hypervigilant. Every single time a patient had any sort of diarrhea, they were calling residents and requesting C. difficile testing. So we had a lot of over-testing and therefore over-diagnosis and false positives. So our response to this was we decided to build real-time clinical decision support into Epic, and we've built in guidelines. So when they try to order C. difficile testing, they've got to meet these 3 guidelines. Okay, they need to be 3 or more watery stools, preferably over 2 days. They shouldn't be on laxatives, and there shouldn't be any other causes for the diarrhea. By building these guidelines into Epic, we got a 50% drop in the number of orders. So again, that shows the power of clinical decision support if you can build it into Epic or your information system. So I'm reaching the end of my talk now. I've talked about several different topics where we've made interventions, and I've talked about the financial impact of those interventions. So what you want to do is when you make these impacts in your hospital systems, you want to take credit for them. So it's great if you can systematically measure your data. When I talk about things like, you know, what's your turnaround time in your emergency department, what's your number of C. diff infections, it's really great if you can monitor that. You can create a list of achievements you've made. These things are really important when you're negotiating Part A contracts, talking to your hospital administrators about the financial impact of the lab, showing them it's not always about just the bottom line of the laboratory, it's the effect that the lab has on the entire hospital system. And then you got to get out and share the message. And I do this whenever I can. I go to departmental meetings, I go to performance improvement committees, I'll talk at medical staff meetings, I'll even go to the medical executive committees and speak to the leadership of the hospital about what the laboratory is doing. It's also very important you have at least a monthly meeting with your hospital leadership, someone from the C-suite. You guys want to discuss strategies, talk about your successes and failures. It's also a great opportunity to plant seeds. You know, when you need to bring new tests, new instruments into your lab, a lot of times it takes a year, even 2 years to get these things going. And what I like to do is start talking about it a year or two ahead of time, and then I talk about it over and over again until they're so used to hearing it, they just sort of take it as gospel that we need these things and they understand, and it doesn't catch them by surprise. And again, always phrase things in terms of both patient care and financial return. So we're building a new hospital or a new laboratory here at Bronson, and the reason I mention this, and this is my very last story and then I'm done here, is that we went to the board of directors, we got approval for our new laboratory. This was last spring, and we had all the plans ready to go. And you know what else happened last spring after we got approved? Tariffs, steel tariffs, aluminum tariffs. All of a sudden, overnight, the cost of our laboratory went up significantly. We were out of budget before we even broke ground. And they told us we had to redesign our lab, and we had to cut like 10% of the costs. We had to move support services like our education team or point of care team. We were going to have to move them out of our new laboratory. And fortunately, I had an opportunity to do this same sort of talk, a value of the lab talk, to the board of directors. And I went and gave a talk to the board of directors about the value of our laboratory. And we were right in the midst of making these very painful changes in our new lab. And about 2 weeks after I gave that talk, I got called into one of the executives' offices, and they said, Dr. Pearson, we changed our minds. We're sticking with the original plan for the laboratory. We are not going to cut it. We're not going to alter it. We're going to go ahead. And I can't say that my talk had everything to do with that, but again, I'm trying to promote the concept of you really got to get out and get your message, and even take it all the way to the board of directors if you get that opportunity. So here are my conclusions. Number one, pathologists and clinical teams need to interact. It's really great when you have a diagnostic management team, when you meet with your clinicians on a regular level, when you go to their performance improvement committees. So number one, you really need that face-to-face time. Number two, new technology. When you bring on new tests, they should pay for themselves. They may not pay for themselves in terms of reimbursement or what you get paid in that way, but they need to pay for themselves down the line. It could be shorter length of stay, fewer antibiotics, better outcomes, lower costs, but all these things lead to higher patient satisfaction. They also lead to higher clinician satisfaction, and your laboratory will be rewarded for that. So again, the real value of the laboratory is no longer can we look at the laboratory in terms of volumes or cost per test or how much profit is the lab making. We really want to look at the laboratory in terms of what we contribute in the cost savings per diagnosis, per patient, and the better outcomes that we create for our patients. So again, I tried to give you real-life examples, things like shorter time in the emergency department, things like spending less money on treating a patient with pneumonia, things like cutting down on the number of hospital-acquired infections. All these things translate into real money that your hospital, that your executive leadership, that your board of directors can see and appreciate. So my final statement is an investment in our laboratories is an investment in the future success of our healthcare systems. And it is our job to get that message out to our clinicians, our executive teams, and our board of directors. And that is the end of my talk, and I'll go on to the Q&A session now.
Thank you so much, Dr. Pearson, for sharing that wonderful presentation with us. I would like to remind everyone in the audience that you can ask a question via the Q&A dialog box in the right-hand panel of your screen. But before we begin the Q&A, we'd like to take a quick poll about today's program. On a scale of 0 to 10, how likely are you to recommend this webinar program to your friend or colleague? We would greatly appreciate it if you could take just a minute to enter your response on the right side of your screen. LabLeaders and AACC strive to continue to bring you the relevant and actionable insights to empower laboratory professionals. All right, well, while that continues, we'll go ahead and begin our Q&A session with our speaker, and I see there are already a few questions lined up. So, Dr. Pearson, question number one is, how do you prepare your staff for the transition to high-sensitivity troponin?
That's a great question. We spent literally a whole year. We started in January of 2018, and we didn't go live until November of 2018. And the first thing you have to do is you have to win over some physician champions in your various departments. So the first team that I won over was the emergency department. I got the leadership of the emergency department doctors to be on board with this. Then I worked on the hospitalist and even the cardiologist, get them all on board, and also the executive team. And I had to do probably 6, 7, 8 different presentations, present to them the European literature, the value of going to high sensitivity troponin, show them those 20% savings, et cetera. And then the other really difficult part is building the algorithms. And you really got to get a very small multidisciplinary team. So again, like one emergency department doctor, one cardiologist, one hospitalist, et cetera, and then to come up with your own protocol. So next.
Thank you. The next question is, how do you handle low-level positive troponin results?
Another really good question. So that is the challenge with high sensitivity troponin, is that you're going to get positive results above the 99th percentile that on the old standard troponin test might well have been negative. And so my main answer to that is you really have to look at the delta. You really need to look at the second value. You always have to be alert that this could be chronic kidney disease. It could be congestive heart failure. You got to match it to the symptoms. Again, you never diagnose a myocardial infarct in isolation. You're not just looking at a troponin. You got to be looking at the EKG, at the symptoms. A lot of places use the heart score. We happen to use the heart score here. We're getting fewer admissions. We're getting faster rule out. So again, the answer to that question is you have to get serial values and look for a delta or lack thereof.
Great, thank you. Our next question is, what do you think are the biggest things that have helped you to be a leader in your health system?
Ooh, it's another tough question. I think for me the biggest thing is it's FaceTime, it's getting out of the office, it's being a regular member showing up at performance improvement committees, at medical staff committees, and it's not just showing up. I'll actually show up and have presentations. I'll show up and I'll talk about procalcitonin at these different meetings and promote the use of that. And you actually want to get to the point where you're a regular member, where the physicians, that take care of patients in your hospital system are so used to seeing you at meetings that they consider you a member of their team, and then they start coming to you and reaching out to you. So I think that would, if I had any sort of secret to being a good leader as a pathologist in a hospital system, that would be getting out and getting that face time with your clinicians.
Great, thank you. Our next question is, for reference labs, do you suggest sending out a sales rep to each client ordering inappropriately, or could we try sending out customer bulletins and see where we get pushback?
I actually do both of those things. We do have outreach support representatives that I often use to try to get that kind of information out there. A lot of times they'll do the research for me. They'll go to the office and maybe find out what's going on. We do also use the memos sometimes. So if we see a test, a good example of that might be overutilization of like dihydroxy vitamin D, unnecessary testing for that, is we'll create a memo approach. We'll look for our guess what I would call frequent violators that order these tests too frequently, try to send them an update. Sometimes I'll just reach out with an email to them. So we use both approaches, but having a good outreach representative or an outreach team that can actually go to their offices is very useful, because again, they develop relationships out there and then they can bring up these topics.
Great, thank you. Our next question is, how should labs or lab directors, your PhDs and or MDs, advocate to be part of diagnostic management teams like the PharmDs have? Another
good question. I think what helps is, and you're right, that the pharmacy teams already go on rounds. That's just a normal, everyday thing that they do. And I would say if kind of your question is how do I build or initiate a diagnostic management team, I would say one of the very first groups to reach out to would be leadership in pharmacy. They already have these connections. They're already on board with the concept. Then the next thing to do is you need to find a physician leader, involved on the clinical care teams. If you're in an academic center, that's a real sort of obvious choice. Pick an academic leader, a teacher who sees the value in this, and then build a team. And all it really takes is a nucleus to get it going. Again, we happen to use the Western Michigan University academic team that happened to be rounding on the hospital patients, and we built it with them. But so reach out to a key physician leader and then start simple. You don't have to go with a real complex DMT that meets every day or deals with real complex situations. You'll be amazed if you can get one going at all. You'll be amazed at how much you learn as a pathologist or as a laboratorian just by showing up and meeting with them for half an hour. It's always two-way information going back and forth between the clinical team and the pathology and lab team. And also, again, whether you're a pathologist or a PhD, bring your lab leaders with you. Bring your head of clinical chemistry, bring your head of microbiology, and you'll have a much more powerful diagnostic management team when you get there and meet with these physicians.
Wonderful, thank you. Looking at time, it looks like we have time for about one more question. So, Dr. Pearson, it looks like you're having what appears to be great success mining data to investigate and monitor trends and responses. Could you please share the tool or tools that you are applying?
Yeah, that's almost an unanswerable question. What I do is I go to the EPIC team and I beg, I plead, I go to the chief information officer and I make my case and I say, look, there's a lot of money involved here. Look at our blood bank budget. Our blood bank budget's over $1 million a year. Please give me the resources to work on this. But unfortunately, I think as all of you know, and I'm not taking a jab at EPIC, it doesn't matter whether you're EPIC or Cerner, but the data mining is one of our biggest challenges in the laboratory and as pathologists. And if anyone else ever figures out the answer to that, please let me know. But every meeting I go to, I hear the same thing of how hard it is to get that data. So whenever I start out a project, I try to lay the groundwork at the very beginning. We need this data, and we need our EPIC analysts to help us with it.
Wonderful. Thank you so much. This concludes our Q&A. So we'd like to once again thank you, Dr. Pearson, for providing this excellent presentation. There were many inquiries into requesting a copy of the slide deck. So in order to do that, please visit lableaders.com and select the Connect button. So thanks to all of you in the audience for listening to this LabLeaders webinar today. Please be sure to mark your calendar for next month's LabLeaders webinar, Optimizing Microbiology Lab Operations in the Era of PAMA, with Dr. Glenn George, which will take place on February 6th. When you close out of this webinar today, you will be taken to the AACC website where you can gain your Accent Continuing Education credits. Later today, you will receive a message from AACC with the playback link to today's webinar. If you have any questions following this program, please call our customer service line at 1-800-892-1400. Thank you, and have a great rest of the day.